Good morning. Welcome to this session. So we're in the session Supporting Self-Management and Patient Activation. And I'm Maureen Markle-Reed, and I'm co-moderating with Mandy, and I'm from Ontario, Canada, Professor Emerita in the School of Nursing at McMaster University.
Hi guys, lovely to see you. I'm Mandy Andrew. I'm from the Health and Social Care Alliance Scotland.
Okay, great. It's so great to see everyone. So just a couple of housekeeping items. If you have questions, we have a microphone, and it's really important to speak into the microphone because we have people joining us online as well as in person. And if you could just give your name and organization before you ask the questions so that people know who you are, that would be fantastic. If you could also just look at the app, you'll be able to see the biographies for each of the speakers. So I'll be introducing the speakers by name and their title of their presentation, but their biographies are available on the app. So it's a very busy morning. We have 7 presentations and 9 speakers. So we'll keep to time as best as we can. And we look forward to hearing from all these wonderful presentations. So thank you very much. And our first presentation is Olga Espegren, and she's going to be speaking on captivating debrief, how it made me feel, made me engaged, and improved my self-efficacy. So thank you.
Thank you. Ladies and gentlemen, thank you for attending this session and for your interest in listening to me. I will now present my master thesis from BI Norwegian Business School, written with fellow student Tor Einar Jacobsen and under the guidance of Professor Arne Karlsen. The world is facing an enormous demographic challenge. Soon, we must provide health services to twice as many people with today's staffing. A global survey shows that only 17% of the workforce are actively engaged in work. And we know that organizations with thriving employees, they perform better. Self-efficacy is central to retaining personnel. As a department manager, I have been, and still am, curious to learn more about what makes employees flourish at work. Furthermore, can capacity in healthcare be increased by releasing more commitment and self-efficacy in the individual and increase performance in teams? The aim of this qualitative multi-method study I'm presenting to you today was to explore what facilitators perceive to be present when they experience extraordinary simulation-based learning in a municipal healthcare setting. Have any of you heard of or participated in simulation-based training? Do you want to raise your hands? Not many people know about it. My name is Olga Espegren, and I live and work in Norway, and I'm a department manager at the Center of Development of Institutional and Home Care Services. And Kristiansand Municipality is our host municipality for this center. And there's a center like ours in every county in Norway. Maya Angelou has said, "I have learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel." And that's important in simulation-based learning. And my curiosity for simulation-based learning has grown from experiencing the thrill and engagement employees showed when they returned back to the office after successful facilitating simulation-based learning for different community healthcare workers. Simulation is a pedagogical method and based about recreating a realistic situation in a safe environment with the goal of practicing, learning, testing, or gaining increased understanding of systems or human actions. Simulation as a method has proven to be effective in enhancing patient safety and reducing patient injuries. The method can be used to train skills in most areas of competence, from complex surgery to observational competence, to practicing patient conversations. The person who leads a simulation training is called a facilitator. A typical training with medical simulation takes just over an hour, and it consists of 3 parts, as shown here. A brief, followed by a practical exercise, and followed up with systematic reflection called debrief. Reflecting can be described as a process where you take a step back to ask yourself questions about what happened and to gain insight into an understanding of how you can act further on the base of experience. We explored the good stories of what brings life to a debrief through 7 semi-structured individual interviews of facilitators and 2 focus group interviews. We also conducted a physical workshop with story cards that are shown here on this slide. The story cards linked images and quotes from the individual interviews. This research design with inductive exploratory approach was chosen to get more in-depth narratives of debriefs the participants remembered extra well. In the interviews, we asked the respondents to tell us when they experienced when participants in simulation-based learning or training really learned something, or when they experienced moments of awe or goosebumps. The goal was to obtain rich and positive stories about good simulations. The interviews were recorded and transcribed word for word to ensure reliability. By doing so, it also became easier to extract direct quotes. We first analyzed separately, then together, and discussed our findings in several rounds of analysis. We were inspired by our professor's earlier idea work to work physically with prints and artifacts in the analysis and to follow what we found interesting, what gave us energy, intuition, and our gut feeling. And it was really exciting. And a methodological weakness of the thesis is that it's a relatively small sample of informants, and we're therefore cautious about drawing conclusions that are too firm. We discuss our findings in light of existing research. As one of the authors knows some of the informants through work, we were also aware of possible blind spots because of that. It was an exciting journey to interview informants about moments of awe and goosebumps that they had had during simulation training, to explore these captivating debriefs. For some informants, it had been a long time since they had facilitated simulation training due to the pandemic. Through the interviews, however, they managed to remember back and tell us stories that we found some really interesting results. It seemed to us that what they had actually experienced was almost internalized. After analyzing text and achieving inter-author agreement, we found 4 main themes. Firstly, the theme of the simulation must be perceived as relevant and recognizable to the participants. It can be relevant from the start or emerge gradually, or be actualized by something being said in the debrief. And this debrief is largely about reflection on one's own or others' practice. And there's many examples from the interviews where participants, they changed their sitting position by leaning forward and changing the tone of their voice or even talk more. In short, the mood in the room can change. And there are several examples where it happens at the same time as a discovery that what you're practicing gets really recognizable. And I quote, "Suddenly it became relevant." Another informant talked about debrief where the mood suddenly changed from disengaged mood to euphoric mood in the room. And one of the participants' reflection meant that the topic suddenly became relevant for performing an even better job, and the participants' involvement took off completely. Secondly, we found that the presence of psychological safety and good feelings were important. The participants must feel that it's safe to train, creating a safe room with an atmosphere for learning, not assessment. Also, being able to frame the group to reduce participants' fear of making a fool of themselves. Deliberate use of body language, supportive comments, and follow-up questions create a sense of genuine interest. And in the debrief, verbal encouragement from colleagues and inviting communication was often mentioned. The safe space we found in the empirical data seems to be related to the high-quality connections, but also the importance of a good brief that sets the framework and clearly defines this as a confidentiality setting, which is important to feel safe. What the informants describe in the safe room is very similar to the concept of psychological safety from Edmondson's research. Another theme was to give room for ventilation if strong emotions are evoked, but care not to release the entire energy in the room. The empirical evidence seems logical. Depending on the cause of the strong emotions, these need to be dealt with to the extent they need to in order to move forward. And it's important as a prerequisite for reviving a debrief or pivoting in a different direction. In experiential learning, emotions should be taken into account because emotions can be an obstacle to learning, but at the same time, in learning processes, emotions are used as springboards for learning. It's when you experience that it really affects and moves you that you're open to learning something new or contributing to creating something new. If there is psychological safety in the group, there may also be room to ventilate and talk about difficult or adverse events that have occurred, which often we as health professionals often don't have the ability to do. Being able to ventilate and relieve pressure, perhaps getting inside the panic zone, is also about good experiences, a sense of coping and psychological safety. The last theme found was co-creating new solutions by discovering new insights through reflection. New insights can create new collective mastery. An informant said it was the participants who discovered that you actually could do this differently. And everyone learned something from others thinking out loud too. A co-created new insight is explained as follows by one of the informants. A good debrief is when the ball bounces from one to another. People can become engaged in creating something new in their own everyday lives. Goosebumps experience can be a result of that, but it can also be the case that it can be a good debrief even if there are no new insights created. It can give the participants more knowledge about something, but not necessarily new insight. In the light of integrated care and in teams that achieve cohesion, people will commit to the decision made and work hard to implement it. Based on our empirical data, there seems to be a strong correlation with what breathes life into a debrief and what creates good performance in organizations. One of the informants sums it up like this: seeing how she felt she mastered and the enthusiasm she was left with, that's what it's all about. Mastering in safe conditions. Through our findings and in conversations with the informants and later discussion against theory, we believe that systematic experiential learning through increased awareness and especially through high-quality connections can support innovation work in the health sector and at the same time make a difference in the individual employee's everyday work. Empirical evidence from our study may suggest that simulation-based learning and training, if it's of high quality in the workplace, can breathe life into a working environment, but also providing a stepping stone to better psychological safety and hence better patient safety. This learning method, when employees master skills and improve, may also stimulate to flourishing workers. And with flourishing workers and workers that do a better job, the workplaces may flourish, and that can improve capacity in the workplace and healthcare, but it must be studied further. Thank you for your attention.
Thanks very much, Olga. If you want to just do it, I think we have a few minutes for questions. And for those of you joining us online, you can type your questions into the Q&A. Any questions?
No questions?
No questions? Okay.
No?
All right.
But I will. I just want to look into more about simulation-based training. I think it's a really good method to make organizations thrive in the health center or healthcare municipalities and also in hospitals. An important way to improve communication, which is important in integrated care. Thank you.
Great. Thank you very much. Thanks again, Olga. So our second presenter is Nathalie Lambrechts, and she's going to be speaking on tailoring community preventative care to personal health needs, a data-driven and participatory approach. So welcome.
Okay. Good morning. Thank you all for coming here, and thank you to the organization for giving us the opportunity to present our project. My name is Nathalie. I work at Vito, which is a Flemish research organization located here in this Antwerp area. We did this project together with Domus Medica, which is a GP association in Flanders, and with Liga, which is a living lab also active in this region. So the project, it's called Bebop. It's actually a technology we developed. And a technology, it's actually a basic website, an online platform where we put tools for citizens to use themselves to manage their own health, and with a particular focus on health promotion and prevention. And as I said, a participatory approach, we did this from the beginning by design in co-creation with all stakeholders involved. So we worked with end users, with possible end users from different sectors, different ages, different socioeconomic status. We worked with caregivers, different types of caregivers, and we worked with local community, local policy makers, because we want to use this tool in a local setting. From this, we learned that the tool should work on personal goals, easy feasibility, and that follow-up should be provided, that it should really be embedded in the local community, and that it should be integrated working with already existing healthcare systems, not another app, not another platform. So central in our platform is what we call the health guides, or in Dutch, de gezondheidsgids. It's something that was developed by our partner Domus Medica, and the GPs already used this in their practice in the 90s. It was to evaluate their patients when the GP had time left, when he wanted to work on prevention or felt that it was needed. And this time left, it's something that, as most of you will know, by today, there is hardly room for this anymore. So also the reason why we wanted to make this tool digital and bring it to the citizens themselves, to learn them how to work with it themselves. So what is it? It's a screening, it's a survey, and it asks you as a patient on your medical history, your family history, your lifestyle, your personal preferences, and it gives you a personal risk on developing chronic diseases. As I said before, integration in the existing healthcare system was important. That's also something we learned from previous co-creation with healthcare professionals. So we worked hard to get it implemented into national e-health structure. So this means concrete that when you as a citizen you complete the survey, at the end you have the possibility to select your personal GP in a list, and you can send the data to your electronic health record so your GP can do follow-up when you meet him at another visit. Together with this, there is some kind of threshold, perhaps, to citizens. It's the fact that when you want to use this system, we need to be absolutely sure that it's you who's completing the survey. And it's also true because we ask very sensitive data. We ask you about your family history, your alcohol consumption, your weight. So these are all data you don't want to be laying out there. So you have to log in through the e-health login procedures, which is for the Belgian people who will know it. It's the EID you use. It's me. It's an app that certifies it's you who's logging in and nobody else. So when you completed the survey, this is what comes out of it. So sorry for the Dutch, it's a print screen, but it's about 10 different domains in prevention setting on, related to chronic diseases like physical activity, vaccination, screening for cancer, your weight, alcohol consumption. So you get a personal advice. How are you doing on this typical domain? Now, this is a good start for self-management. So now you know, okay, I need to work on this, but how? How will you do this? And that's what we also want to work on in this platform. We want to ensure follow-up, that you can do something with it. And for these personal services, we also want it to be as easy as possible, that the citizen only should give his data one time, only once. And for this, I'd like to refer you to a poster we have on our website. It's on VR. It's a project we are doing together with the Flemish government on how to make this feasible, how to use technology to make sure you control your own data. You have to complete them only once, and if wanted, you can also share them for research and development. But as said, I will not elaborate on this here, but please look to our poster for more information. But how does this look like then in practice? Well, you have now your data. They are now being reused if you want them by other applications on the platform. For instance, we have a chatbot. It's called Bob. And Bob helps you with more information on these domains. So for instance, you have a question on vegetable and fruit. I should eat more, but what does this mean? Well, Bob guides you through your questions, and he leads you to recognized Flemish organizations that work on these topics. And we have this for each topic in there. So you get correct qualitative information if you want to know more. Another one we developed, this was active a year ago, it was the COVID risk score calculator. Again, it reuses the data you put in first to give you a personal risk score for developing, for getting infected with COVID, for getting ill from it, and for being hospitalized by it. It was again meant as a tool to empower and sensitize people on the risk of COVID. So people could see the risk in my municipality is, for instance, for 80% of obtaining COVID, because we used the Cienzano database that was available out there with the numbers, and we combined it with their personal lifestyle. How many contacts did they have? Did they wear protective masks? Were they vaccinated? And so people could see, if I am vaccinated, my risk drops significantly. So again, a tool to sensitize the people. But now we are here as in the community care to learn more about that. And for this, we also developed our local action plan. This was done together with local policymakers. So we learned that there is a lot that local municipalities and local caregivers offer to people, but very often it's not found. So what we wanted to do with this application is bring this all together and bring it to the people in a tailored way. So when people learned, for instance, they had to do more physical activity, they are directed. Here you see, it's the app reuses this information, and it tells them what there is in their neighborhoods to work more on this. One of the examples we have is bewegen op verwijzing or physical activity on prescription. It's another Flemish initiative. And so we can bring this all together and bring it to the people in a very tailored way. And also healthcare professionals can use it to do this kind of referral. So this is the design of the tool. Now what happened? We are about 1 year after launch, and we have had about 1,000 people who use the app. So this is a result we are quite happy with. And what does these data learn us? So these are the data from the people that agreed to share their data for research. So if we have overall, I think it's about 5,000 who tried it, and about 1,000 who gave us our data. So there's already a lesson in there. Why the decrease in people who shared their data? But I will come back to that later. If we look at the age distribution, you see it's actually quite nice. For the digital tool, we have here over plus 65, 10%, but I have to admit that we put a lot of effort in there. There are colleagues in the room who know this. We did a lot of co-creation directed to these target groups to see what do they need to use it. So we recruited them very passively, let's say through flyers, publication in local magazines, and then of course our active co-creation and live tests. We did this in 5 municipalities. I forgot to mention this, so we worked together with them how to launch this in this Kempen area in Flanders. Now, further looking into these data, these 1,000 people, who are they? We see that they are quite healthy, actually, and it's of course good, but also a pity, because you want to reach those who are in need of this tool. So we see that smoking level is very low, physical activity over 50%, it's rather okay, healthy food, lots of alcohol. Also gives us an indication on the level of, on the education level of the people. I will come to that later also. Well, actually, here is the graph, so we can go in detail. So here are the same parameters. So for instance, alcohol is here, and you have the age categories, and you see it's not the younger people, but actually 55 plus who are doing most of the alcohol consumption, which is quite typical in Belgium. Vegetable consumption, we also see that they're the younger group. The elderly group is doing better, and same for physical activity. So these are very interesting findings for a local municipality to go and work with. What domains and who to target for these domains. But yeah, if we see this and we know that it's very important if we want to use this tool, for example, for population health management, that we are in effect in a great need for representative samples. So we need to reach all people, not only the ones who are already living healthy, not only the ones with higher education or the younger group. We need to reach all of them, and then the data become representative and a community can work with them for their local population health management. And for this, we need support. We need support from the local caregivers to help us and reach them. And we know this because we did these co-creation sessions. We did them before, we did live tests, we did focus group afterwards. And what we learned from them, and also from surveys we did, is we did them with informal and formal caregivers. We did them with older adults. We did them with people with lower socioeconomic status. And so we learned, indeed, from the survey screening for technology acceptance, that they all indicated some degree of digital literacy definitely is needed here. But it was also nice to find out that most of these people said that for them it was not a problem to get peer support and as such obtain this threshold for digital skills that were required. Fear of the internet, it's something that pops up here in red. But on the other hand, concerns about data security are quite good. So a green scale means a very positive attitude. So that's also something very interesting to know. There is some degree of trust, although, and especially when we did focus groups with the people with low education, it was the most important aspect that came out, the distrust they had towards technology. Using EID, they said, oh no, government is going to want to know everything about me. So they were really hesitant to use it. And very interestingly, what they said was, if I will do this, if my GP tells me, I trust him. If he says me, I need this, I will do this. And I think for us, that's a very important lesson to work with in the future. We need their advice. We need these professional caregivers to reach these people who are in distrust, who need prevention or health promotion the most. Another thing that came out is this one here, self-efficacy. Well, actually, we did this mostly with these older adults. It was a very limited sample, of course, but it was quite good. They were all convinced that the tool helped them managing their own health and promoting their health, but they pointed out that sustaining this would be a point to work with. So, learning all this, and now we need to come up with how will we proceed with this, and that's what we call the switch to a community care approach that we will be working on. So we are investing together with some dedicated municipalities now on this approach of really referral and follow-up. I heard it before in workshops and sessions. Everywhere a citizen goes, he needs to get the same message. And we are working in this integrated care setting to have them being delivered this message not only by their GP, but by the social worker, by the worker from the name escapes me, the mutualities. So they hear it from a lot of different sides, that they have to work on it, and that this is a tool that they can trust and that they can use. We also invest in digital literacy skills and health literacy skills, so we work together with also organizations that invest in that, not only for the citizens, but also for the caregivers. So it's some kind of train-the-trainer aspect that we are implementing here. And finally, the effect of participation, co-design, it's something that we find really important. We really want to do this bottom-up approach, so work even more with citizens. Also for the activities that are being organized in a community, let's do this bottom-up. We saw this in COVID, this walking groups, and also really citizen approaches. They should also be offered. They should also be out there next to the official organizations that offer activities. They are equally important. Okay, I think, yeah, I'm finished. So I just wanted to say that we are doing this in different care settings, so in primary care zones as well in secondary care. And to sum up, so this is a tool we developed for personalized health promotion and prevention. It's citizen-centered with participatory design. We integrate it in existing care systems. I think this is very important and something we will keep on working on to integrate even more systems. And as such, we can come to a data-driven approach for health population management based on community needs and assets.
Thank you very much, Nathalie. Unfortunately, we're out of time, but I did notice that there is a question online, and if any of you have questions, if you'd like to point, I'm sorry, we don't have time for questions, but if you have any questions for Nathalie, if you could post them on the Q&A or speak to Nathalie after the session.
Okay.
So thanks again, Nathalie, for an excellent presentation. Very good. Okay, so our third presenter is Anja Marchal. And Anja will be speaking on promoting the professional reintegration of people with rheumatic musculoskeletal diseases based upon disability management principles. Thank you.
Hi everyone, I'm Anja. I'm a member of patient organization Rheumatoid Arthritis Liga, RA Liga. I work also at Rheumanet. Rheumanet is a Flemish platform for patient organizations within rheumatology in Belgium, and I work there as a certified return to work coordinator. So the RA League is member of two patient organizations, the Flemish Patient Platform and Rheumanet. Rheumanet, I already explained it. Both patient organization, both platforms find it very important to improve the quality of life of people with a chronic condition or a rheumatoid musculoskeletal disorder. Both organizations, Flemish Patient Platform and Rheumanet, find it very important that patients are heard everywhere on every level within the society. And we train and support patients to be patient experts. Rheumanet works together with Patient Expert Center, who trains the generic part of the training, who gives the generic part of the training to the patients. It's about GDPR or ethics or the way medication goes. And Rheumanet offers people with an RMD the specific training about RMDs and the social community around it. We found that having a patient within community, within a multidisciplinary setting is very important, and we say nothing about a patient without a patient. Working with a chronic condition is one of the life domains both platforms are working around. We want to prevent people from falling out of work or going or returning to work as soon as possible. We want to sensibilize the government and promote communication with all stakeholders, the different kind of doctors who are active within the professional reintegration process, but also specialists and the government. So when I talk to you about RMDs, so rheumatic musculoskeletal diseases, you have to know that there are more than 200 kinds of RMDs in the world. So it's not only rheumatoid arthritis, but also spondyloarthritis, osteoporosis, arthrosis, osteoarthritis. So we have inflammatory and non-inflammatory disorders. It can be on the height of the joints, but even so on veins or on eyes, on level of everything in your body. I am a certified return to work coordinator. I'm trained by our National Health Institute, and it is a whole training to become a return to work coordinator. Next to that, I also followed the training of patient expert at Rheumanet, also training as a peer mentor, and I have professional expertise. I'm a social assistant, and I worked for the health insurance and a special organization for people who have difficulties to return to work. For Rheumanet, because I work there as a certified return to work coordinator, I did research Reuma Werkt, so working with an RMD. I support people, I still do this, I support people with RMDs who have questions about work. It can be professional rehabilitation, reintegration, it can be a lot. And during the years 2018 and 19, I asked all the coaches that I supported to fill in questionnaires, surveys, and this is the research Reuma Werkt. Next to that, I also asked stakeholders to complete different kinds of surveys and questionnaires about information flows, where they find information about working with an RMD. Is it correct information? What do specialists do? What does a specialist do when a patient comes over and tells about problems at work, and that so on. So the setup for the research is to find an answer to different kinds of questions, and the focus lays on information flows, specific needs, barriers, and supporting systems for people with an RMD at work or returning to work, and the value of patient expertise and working via the principles of disability management. This is a poster with all there is about the research. It's a poster shown at EULAR, the European Congress within Rheumatology, and it shows the conclusions of this research. we know that there is a lot of information available for people who have questions about professional reintegration, but we know also, and the former speaker told us also, that persons don't find the correct information easily. And if patients or persons find information, it's not always tailored. And in the research here at Reuma Werkt, even 19% of the persons didn't find tailored information or information about professional reintegration with an RMD at all. So there's a problem. There's a lot of information available, but people don't find it in Belgium. There are a lot of possibilities in Belgium, but there are a lot of differences between regions. Thinking about Flanders, Wallonia, and Brussels. But within the regions, there are also a lot of different kind of possibilities, and people don't know where to find or to go to. They have specific needs, not only with a chronic disease, but also with RMDs. There are specific needs. Sometimes people with an RMD can work like every normal people does, but we have also flares. So it's a chronic condition that isn't always stable, but it can be stable for a couple of years, for example. But it's also very individual. So you have to work individually and look for specific individual needs and support. And that working via the principles of disability management is an added value, because there you look at the biopsychosocial context of the individual and you link it to the working place. You work together with stakeholders like occupational doctors or the specialists, and you work towards tailored solutions. And last but not least, I'm a patient expert, and we noticed that during and in the coaching, the support that I give, that people dare to speak candid, open. They dare to say things they don't dare to do to a professional because they are afraid to have sanctions financially or practical, or that they lose chances. So it's an added value to be next to the patient instead of in front. So this is my really short explanation about Reuma Werkt.
Thanks very much, Anja. Do we have questions? Any questions? Okay.
Can I just ask?
Yeah.
I like the point, and we hear that so often, that finding information. We find that trying to find information can be very difficult. Then once the information is found, as you quite rightly say, it's very complex. What's the impact of the work that you've been doing? As you say, you're walking alongside the patient. What's the impact of the work that you're doing about them being able to unpack the complex information? What's the impact that that's having on them?
I started working at Reumanet in 2015 or 16, and I see that we worked on getting to know all the rheumatologists, all the specialists in Flanders, because we're active in whole Flanders. And I gave information sessions to the specialists, but also to the patients. And the more they know me, they trust me, the more there is a direction and advice to contact me directly, because they know, okay, Anja knows what she's talking about. Okay, she's a patient, but she's got the knowledge, she's professional. So I can give the advice to my patient to go to her. So I see a decrease, is it a decrease? Yeah, of people who are contacting me. And I see also that the larger part of the people who contact me now, but also before, are people who are still at work. And that's, for me, a great signal, because it's important that people stay at work. It's more prevention. And the thought that I can help people to stay at work and remain at work, instead of letting them shipper and seek for help, if I can throw the line and say, okay, there's a way to go, maybe it's another way that you thought about, but there is still a way to remain at work. I see it gives a lot of confidence also to other people when they contact me. So, and that's I see a decrease in numbers of people who are contacting me, but also a decrease in numbers of people staying at work. There is also a change in legislation in Belgium. So in 2022, Two, there started also return to work coaches at our health institutes. So when people getting a health insurance now, they are immediately contacted to have or to gain the proper information about returning to work. So I know that those people who are longer at home in sickness and getting a health insurance, there is now a solution at our health insurances, but I'm still there. And it's, the same. I don't see an increase of numbers of people who are contacting me because it's the working people, they don't find anything or any way to go to have the correct information. Yeah, thank you.
Any other questions? Any other questions? No? Okay, well, thank you again very much, Anja. Excellent. So we have two presenters for our next presentation. We have Bert Morrens and Sam Van Bastelaere, I'm probably not pronouncing it right, and they'll be speaking on an innovative toolbox to develop and evaluate a personal budget system together with chronic care stakeholders in Flanders and Europe. So thank you.
Thank you. Good morning. We are very happy to be here today in this beautiful location to speak about the UNIC projects and how we are trying to optimize our system of providing care and support for people with disabilities in Flanders. Firstly, Bert and I both work at the VAPH, that's the Flemish Agency for People with Disabilities, and we are the governmental agency that finances and organizes care and support for people with disabilities in Flanders. To further optimize our system, we have joined the UNIC project, that's a European project in which we work together with other countries for developing and evaluating long-term care and support systems. But how did it all begin? Before 2017, we still had a traditional supply-driven system in Flanders, similar to the systems in most other countries in the world. All service providers had a license for a certain number of spaces, and we paid a fixed amount per space. Usually, only all-in packages were available, which left the person with a disability with little choice. Then, in 2009, we ratified the UN Convention on the Rights of People with Disabilities. This convention is an international human rights treaty, and it aims to promote and protect the rights of people with disability. The convention is built upon several core principles. It emphasizes the importance of improving overall quality of life for persons with disabilities and recognizes the importance of respecting the autonomy and individuality of persons with disabilities, enabling them to lead self-determined lives. It encourages the provision of flexible and person-centered support, enabling individuals to set their own goals, make decisions, and actively participate in shaping their own lives. It also highlights the importance of a demand-driven approach that respects individual choices and fosters empowerment, independence, and inclusion. These core principles guide governments, organizations, and individuals in creating inclusive policies, services, and environments that uphold the dignity and rights of individuals with disabilities. To put these systems into practice, in Flanders, we introduced the personal financing system in 2017. The system consists of two steps: directly accessible support and personal budgets. Directly accessible support is limited, disability-specific support in the form of assistance, day activities, residential support for individuals who occasionally need help. No application to VAPH is necessary. The second step are personal budgets, which are tailor-made budgets that allow adult individuals with disabilities to purchase care and support from different sources. An application to VAPH is needed for this. At present, there are about 27,000 budget holders and 23,000 users of directly accessible support in Flanders. The person-centered financing system is based on concentric circles of care and support sources. The person with the disability is at the center, followed by close family. Family, friends, and informal contacts form the third circle. Mainstream services the fourth, and specialized care and support the fifth. These circles are complementary and dynamic, which means they complement each other and can change according to the needs of the person with a disability.
Okay. So we take a lot of pride in the system we have developed in Flanders and that Sam just presented to you. And we are really committed to promoting the underlying principles of that system. But I think, however, on the other hand, we recognize that no system is perfect and that continuous evaluation and improvements are needed. And that's where the UNIC project comes in. UNIC is a European project and that is funded by the European Commission. And it aims to support the transition to more user-centered funding models, such as personal budgets, on a European level. So quite similar to the journey we went through in Flanders, but then on a European scale. And for us in Flanders, it was a great opportunity to share knowledge and to learn from other European partners in other countries, such as Ireland, the UK, Austria, Czech Republic, Finland and Luxembourg. Together with Flanders in Belgium, we work together on the UNIC project. And the project has 4 main objectives centered around the UNIC toolbox. And I will briefly focus on the development and the testing of the toolbox that aims to assist stakeholders in implementing, monitoring and reforming personal budget systems across Europe. So the 2 objectives that you see here on the slide. Now, the toolbox, the UNIC toolbox, consists of 3 tools targeting 3 different levels and 3 different key stakeholders. You get on the micro level the quality monitoring tool for people with a disability, to evaluate the impact of their personal budget on their quality of life. On the meso level, you get the service delivery tool for caregivers to assess the services they provide for individuals with a personal budget. And then on the micro level, you get the compliance assurance tool for public authorities to evaluate the policy system for personal-centered budgets. Now, it's important to stress that these tools are not intended to evaluate the technical aspects and the technical details of a personal budget system. Instead, they are based on the key principles of the UN Convention for the rights of people with disability and is based on the concept of quality of life. So the toolbox, in fact, serves more as a compass, indicating the direction in which further developments and improvements are needed, rather than being an objective and a fixed evaluation instrument for policy. However, we believe this does not mean that the tools consist of random chosen questions, because each tool had a very clear structure with questions covering various domains and subdomains, like you can see here, for example, for the SDT tool, so the service delivery tool for the caregivers. That tool was designed around 6 domains related to the UN Convention, and we all have the same question statements with a fixed scale. So it was very well thought through with the structure in different domains and subdomains. The toolbox will be fully available online as a digital questionnaire by the end of the UNIC project in September of this year. In multiple languages, the languages of the countries that participate in the project. Some tools will be modular, allowing users to answer questions based on their stage of policy development. And the idea is that respondents can fill in the tools and they will receive an individual report with targeted advice and guidance to formulate action points. And the aggregated results can also be used by governmental policy authorities to further evaluate and improve their policy system. Now, in Flanders, we extensively test and validated the toolbox with a piloting phase that lasted for 12 months, in which we conduct a lot of workshops with 3 different target groups, people with a disability, service providers, and the Flemish government itself. And this allowed us to refine and adjust the toolbox and ensure that it meets the needs and requirements of all the stakeholders. So we have workshops in 2 phases with the same participants. First, to discuss the content of the tool on paper, and then a second phase of workshops discussing the use of the tools in an online environment with the same people. So we had a lot of good discussions there. Also part of the testing and the validation process, we have developed and tested a concept for peer-to-peer interviews. This approach aims to assist individuals with greater care needs in filling out the toolbox with the help of a peer. So that's something we are still developing to assist those persons that, so they can also use the unique toolbox. And additionally, the entire piloting process was evaluated by a scientist to assess the impact of the unique tools. So, in conclusion, we believe the transition to more user-centered funding models in Flanders, but also in other European countries, is always progressing step by step and needs continuous evaluation and improvement. And in doing so, we believe it is important to keep the focus on the underlying principles and the values for that transition and not get blinded by technical details. And to always put the person with a disability at the center, both in the development and in the implementation, but also in the evaluation of a policy system. And we believe the unique toolbox can be of help there, can be a valuable instrument to evaluate and even to scale up a person-centered budget system. So we encourage you all to take a look at the website where you can still see the tools in development. The website is over there. So with that, that was the presentation. So if you have any questions, or if you want to contact us, the information is over there. Thank you.
Thank you very much, Sam and Bert, for this excellent presentation. Any questions? There's one here.
Thank you very much for the beautiful presentation. It was very clear. Is there also room for the informal caregivers in the tool? As the informal caregiver is often the right hand of the person with a disability. And secondly, how is your distribution plan planned after, from the moment that it is on the market? Will it be paid, or does the PVD has to buy it, or what is the distribution system?
Mm-hmm. Okay, thank you. First question, I think the informal caregivers, I think the most logic way is that they fill the quality monitoring tool. So the first tool on the micro level together with the person with a disability, and they can both fill in that tool, because that's really about how I use my personal budget, how can I improve the ways that I use that budget. So that, to me, seems the most logic way to fill in that type of tool. In concerning the distribution, in my opinion, it will be a free platform, and it will be an open platform for everybody, so it's not a paid service, let's say. But we realize that there's going to be a next phase when the toolbox is ready to promote it and to get it to the people to fill it in. And that's, I think, why next to this European project, for instance, for Flanders, we need a second project to really tailor it to the Flemish context and to distribute to the service providers, to the local authorities, but also to people with a disability, to promote filling in the tool and stressing the benefits of filling in that tool. I think that will be an important next step for us in Flanders.
Sorry.
Do we have time for another question? Or- Okay, there's one at the very back, Mandy.
Lars Kaiser, University of Copenhagen, researcher, but also an impaired person. I think you should consider the word disability, in particular if you want to get it into a community. Disability is that you are disabled to do anything, then you cannot be successful in enable people. It's better to talk about impairments, as then you will be able to assist, help, and develop.
Okay, yeah, I believe the terminology and using the right terms is an important thing, but in the UNIC project we work with the most used term was people with a disability, and in the UN Convention as well, the term people with a disability is used as the most neutral term, but we will take it in consideration. Thank you.
I think we're out of time, so again, thanks to both of you for your presentation. Thank you very much. Okay, so our next presentation is Dr. Liga Vranken, and she'll be speaking on enhancing transmural continuity of care for vulnerable patients with kidney problems, a mixed methods multi-stakeholder needs assessment. Welcome.
Yes, thank you all for listening to me today. I'm going to talk to you about enhancing transmural continuity of care for vulnerable patients with kidney problems. And I want to start with a little shout out to my co-worker, Katja Swinne. You may see that she is here mentioned here first. She was normally going to give this presentation, but unfortunately she has fallen ill, but I just wanted to give a little shout out. So for the next 10 minutes, you're going to be stuck with me and not with Katja. 10 minutes is not a lot. What I'm going to try to do in these 10 minutes is give you a little background on the project, explain you our goal and research questions, and the bigger chunk of this 10 minutes I'm going to use to highlight our first findings and then take a closer look at what we're going to do next or what our next steps are. A fast background. I'm going to talk to you. I'm going to talk about preventable readmissions today. Part of unplanned readmissions are preventable. Readmissions that are preventable are very costly to the system, also to the patient. They lead to very unnecessary professional burden for all professionals involved, and they're associated with negative outcomes for patients. This is partly due to sub-quality of care transitions. This can be a very multi-level problem. This can be due to a lack of communication between healthcare professionals, both from within the organization and between organizations, lack of communication between the professional and the patient. Maybe care is not tuned to patient needs, especially when patients are vulnerable. Could be due to lack of resources, and so on. It's important to focus on preventable readmissions because in Flanders, in Belgium, there's been a recent shift from specialized care to focus more on primary care. The goal is really to reduce the amount of, or number of hospital beds and the duration of hospital stay with a bigger focus on organizing care in the primary care setting and in the familiar environment of the patient, which is beneficial. This is a good thing. But then we need to focus more on these preventable readmissions. The goal of the project was to implement an intervention to reduce preventable unplanned readmissions on a specific department of a Belgian hospital, namely the nephrology department. We had two big research questions. The first research question is, what are stakeholder needs? With stakeholder, we mean professionals, both from the specialized care, from the hospital, but also from primary care setting and well-being, and the patients and informal caregivers. Our second research question is, what are the interventions and strategies, which of them are effective in reducing these preventable readmissions? On what should an intervention focus? Which components should an intervention really have? And what are the barriers and facilitators for implementation, and how can we overcome these? What have we done so far? We started in September. We did a literature study, still ongoing for the remainder of the project, very important to keep ahead of literature. We did in-depth interviews with the nephrology team, or part of it. We already conducted 8, and 3 more are scheduled. Also with recently discharged patients, we conducted 3, and there's still 1 more scheduled. We did a literature study and the interviews in order to map the existing evidence, the current needs, the difficulties, the roles of everybody involved, and also to map the needs of all stakeholders. However, we have a big chunk of missing data at this point. We have not been able to reach professionals from primary care and well-being. We have been told that this is partly due to the fact that we are looking for such a specific population. We are looking for professionals from primary care that have recently been in touch with patients that have recently been admitted and discharged from the nephrology department from a very specific Belgian hospital. But thanks to ICIC and our networking here, we now have found some willing participants, so that's a good thing. First, preliminary results. I would like to first focus on our literature study. Interventions that focus on pre- and post-discharge seem to be more effective in preventing preventable readmissions. Interventions that include self-management and patient empowerment seem to be more effective. Interventions that include telephone follow-up are more effective. Interventions that include medication reconciliation are more effective. It's not clear if there's a difference between single versus multi-component interventions, and so on. I think the biggest message I want to give here, I don't know if you have any experience with reading systematic reviews, but usually there are 2 big conclusions in the discussion parts. The first being that the research that they have reviewed and compared is very heterogeneous, so it's difficult to compare, it's difficult to make strong conclusions. The second biggest conclusion is that there needs to be more research done. But there was a common denominator in all these reviews, namely that interventions that include components of self-management and patient empowerment are more effective. So that's a very interesting takeaway. The first findings of the interviews that we have conducted. So they remembered that they focus on a very specific department of one Belgian hospital, that there is an unclear role division in the department. On the one hand, you have a team of nurses that say it's not my job as a nurse to call the home nurse when there's going to be a transition. It's a social assistant that does this and needs to do this. And then there's a group of professionals that say, no, it should be the nurse that contacts the primary care professionals to assure there's continuity and accuracy of information. Secondly, there's a discrepancy between a patient that is medically ready and what the patient and the informal caregiver actually sees or needs or feels about being transitioned to the primary care setting and the home environment. The doctor really relies on objective clinical parameters, sees the medical records, and declares based on that if a patient is ready to be discharged. But what the patient or caregiver sees might be something different. Maybe they are faced with stairs. They can be literal, they can be figural stairs, things they have to overcome when being transitioned to the home environment that give them anxiety, that they are afraid to tackle, household chores that are waiting for them, that they don't feel ready to do at this moment. And although there is good alignment, or a fairly good alignment between being medically ready and what the patient and caregiver needs, there are still some gaps there. We often heard from the nurses that we interviewed that sometimes they knew we would be seeing that patient again. Empowerment, we have found, is really a two-way street. On the one hand, the patient needs to accept power, needs to have skills to be empowered. And on the other hand, you have the professional that needs to be willing to share their power and take a big role in supporting the patient to become empowered. Something we have heard a lot is that patients are afraid to ask questions. They always have questions, but they are afraid to ask questions. And it's the job of the professional to encourage patients to find manners, ways to facilitate asking questions. We found some other barriers in the department for empowerment. Patient beliefs and attitudes. Professionals are too busy, they don't have time to listen to me. They know what's best, not me. And what I want doesn't really matter. But also their knowledge related to medical issues. I want to stress this. We've heard a few times, if I choose treatment X, then Y will happen. And then afterwards this seems to be false. But also professional beliefs and attitudes. Patients already know this. Sometimes they see patients again and again. Sometimes that's planned, sometimes that's unplanned. But we've seen them, they already know this. Or they're too old to understand what we're saying, or they're too old to self-manage. And there's a hierarchy. It's not a perception of hierarchy, there is still a hierarchy in place where doctor indeed knows best. But there needs to shift something if we want to really empower patients. There are some good empowerment practices in place. There are key figures and champions in the department across all disciplines that can really be the voice of patients. But also good practices from neighboring transplant departments. They have in-room medication, which is an exception in the hospital. So normally there's a rule to not have medication in the room with patients. But in the transplant department, they do have in-room medications, and patients need to be able to understand, explain what their medication is, what it is for, and they need to be able to take it completely by themselves before they are being discharged. They have interactive booklets for patients. Patients are really actively encouraged to write down and ask their questions, and if they don't write down questions or ask questions, professionals will trigger them and stimulate them or really support them to do this. And lastly, there is a very big importance of relational and informational continuity. A big aspect here is trust. Trust between patients and the professionals and the physicians, doctors in the department. The physicians in the hospital change every few weeks, months, and that's a big barrier to build a bond of trust between the caregiver and the patient. And I've already heard in Nathalie's presentation, there was also a big part of trust. I will do this if my GP, so my primary care physician, will say I have to do this. So there's a big contrast between trust in the primary setting with professionals and trust in the hospital setting. And also there needs to be interdisciplinary consultation. There is interdisciplinary consultation. They have weekly meetings. Patient is not there. But the patient, and I've already heard this from Anja's presentation, the patient is also a discipline, is also an expert. Because I said earlier, there is a lack of patient knowledge about medically related things, but the patient knows best and is expert in what they feel about the diagnosis, about the disease, how they cope with it, how they feel about it, what their network looks like. So there really needs to be more. They really need to be more involved when it comes to interdisciplinary consultation. We're still in the current phase looking for these primary care and well-being professionals. We have found a few willing professionals here at the conventions. But if you still know anyone, or maybe you are yourself a professional in primary care that have been in contact with nephrology patients, please contact me later. In the next phase, we're still ongoing literature study, but we will conduct short questionnaires, rapid questionnaires, and focus group to design an intervention, to identify barriers and facilitators to implement the intervention, and design an implementation plan and select implementation strategies. And in the final phase, we're going to implement the intervention and evaluate it. So, if you have questions or input or feedback, I'd be welcome to answer those. And are you working in a primary care setting in or around Leuven, Belgium? That's also important. You can contact me or one of my co-workers. Thank you.
Thanks very much, Leah. for your presentation. I think we have 1 minute for questions, so any questions from the audience? We don't have any online, but any questions? Yes, Mandy?
One quick question. You spoke there about the readiness of professionals to share power. Do you feel the professionals, what level of readiness do you feel the professionals are at?
It really differs. Like I said, there are a few champions or key figures in the nephrology department that are completely ready to share their power or to empower patients. And there are some which you could also see reflected in the professional beliefs and attitudes that are not ready at all, because they feel patients of that age, they see a lot of older patients, aren't ready to self-manage.
Okay, thank you again very much, Leah. Excellent. Okay, so we're moving along, which is great. So we have 2 presenters for the next presentation. We have Patricia Van Pelt and Caroline Masculel. Close enough. And they're going to be speaking on a community health literacy hub. So welcome.
Hello to you all. Caroline and I, we will travel through the story of the health kiosk, but at the speed, because the time is ticking. Working as a health promoter, I had the opportunity to work on a project on health literacy, and especially towards vulnerable groups with the support of the Koning Boudewijn Stichting. Along the way, I met fantastic people of the University of Antwerp, and including Caroline, a post-researcher and passionate about the work of the community health workers. So the university and the kiosk are a team from the beginning of this story. Wait, I have something to... Kijken waar ik op moet drukken. Deze. Ah ja, oké. Ja. Okay. So, let me take you briefly to the start of the small health house who was built by Syrian refugees. They worked at a non-profit organization, Gatam. They connect people to each other and to the labor market. Work is an important social determinant, and it promotes integration and it prevents poverty. The kiosk provides information on a healthy lifestyle and disease prevention to people in a socially vulnerable situation. Often the information is not accessible because of language or the cultural. These people have so many other concerns on their minds that they have little mental space to actively engage with health. The kiosk is a partnership between the local organization, Logo Antwerp, the University of Antwerp, the Borgerhout District, and the ILZ East. And it is an important collaboration with the neighborhood partners and the community health workers. They are really important for our working because they remove a little bit the important barrier of the language. The health kiosk fits with the goal of the integrated care. It is enabling people to maintain and regain their independence and improve their quality of life. With the kiosk, we try to build a bridge between the prevention and the care. Prevention and self-care are as essential to achieving this goal as the coordination of health and social care services. With prevention support,
people should be able to make informed decisions about their care and well-being, develop skills and knowledge to self-manage their long-term conditions. They should remain active in their communities and not become socially isolated. Okay. From the health kiosk, we are fully committed to strengthening the health skills of people in the neighborhood with a specific focus on those who live under the radar. In this, the community health workers and us find each other. People living in social, economic vulnerable circumstances have lower levels of high literacy. So, there is a need for innovative measures to improve health literacy among people living in a socio-economic vulnerable circumstances. There is a need for innovation. We need to be present in the settings of everyday life. That's really important. We must reach the most excluded. So being present in the public space is really important for us. Entering without knocking, without door. We take into account the needs of the target group by being sensitive to and considering the diversity of the target population in terms of language, cultural and educational and socio-economic characteristics. From the beginning, the kiosk was also integrated in the European Spices project. It's a research project on the primary prevention of cardiovascular disease. In this project, the university investigated how to implement interventions around risk assessment and coaching to behavior change for a healthy lifestyle, as well as possible in general practices and welfare organizations. And the kiosk became for them an innovative place to experiment this. So with the kiosk, we make the bridge between prevention and care and access to care. An example is the monthly collaboration with the medical students of the University of Antwerp and the community health workers at the kiosk. They measure the parameters such as blood pressure, the heart rate, asking questions about their lifestyle. When there is a risk, they give advice to visit a dietitian or a movement coach. They are present at the kiosk every month too. And a new thing is that every month now we have a psychologist too. More and more organizations are finding the kiosk for experimenting with their projects. One project now is the University of Antwerp. We have a service project, so it engages students in a unique and innovative project that aims to improve the health literacy of the people, and then the participation of the vulnerable groups. So we are making a think tank so that they can participate at the university. And the second project is from Stand Up to Cancer, and it's a cooperation agreement within the framework of the Smoothly on Chair Walk project. So there they come and they ask us to work together with those vulnerable people groups. And now I give the floor to Caroline.
Are we back at the start? Oh, no. Sorry. Okay, I will walk you through the integrated community care framework, but I won't do it justice because we don't have time. There was an earlier presentation today where they elaborated on the framework. So I also highly recommend to read the report if you're interested. And we will only look at the three main domains that they distilled within the framework. They also have 7 effectiveness principles, but that will lead us a bit too far. But you can, a little bit of advertisement, you can read the full analysis within this paper where we present the 7 effectiveness principles within the community case study about the health kiosk. So I will look at who are the main initiators and drivers. You already met one of the most important ones, and that is Patricia, which you could call in the literature a grassroots initiator, someone who sees a need from the ground and starts to act how we can develop this and respond to this need. She did do that in collaboration with local organizations, and then they applied together for some seed funding. That group of organizations was important not only for, of course, collaboration is always better in this case, but also to gain trust within the community. I already heard earlier, trust is key, and this is also in the health kiosk a central and key element. But next to the core steering group, the person managing the health kiosk on a daily basis is really key. As a person who makes contact with the local organizations, also brings the organizations together so that they can collaborate amongst themselves, but she's also the contact person for people who live in socioeconomic vulnerable circumstances. So she is a real key player in the health kiosk story. And you can see here, she gives a quote where she says, like, creating slowly that trust base was so important. The kiosk wasn't put there from day one. There was first a long process of gaining the trust, getting to know the community by doing a compliment day where compliments were handed out, free fruits and veggies, a partner day, etc. So that was really essential to be able to build that trust. So then when we look at the center of focus, the second main domain that the ICC framework presents, the center of focus, as Patricia already said, is improving health literacy and stimulate healthy living. But before being able to do so, you have to first build community, and you have to also pay attention to the spatial environment. So building community, I'll say it again, trust is key here. I can't stress it enough. And building those relationships with local organizations is very important as well. Then, once that trust was built, we were able to set the kiosk, the wooden structure that Patricia showed, on the square, being able to start the real activities of the kiosk. And these real activities then link to the main element of the care and the well-being, the stimulating the health literacy and healthy living. And the person who runs the daily operation says, like, just standing there on the square, open doors, that people ask curious questions like, what do you do here? Why? What is this little thing? And that's often a good starting point for people to have a first conversation. There are also free fruit and vegetables from a local wholesaler who donates them. So it's also kind of against food waste because the food is still good, but it can't be sold anymore. And that's also often a very good starting point for a first conversation about health eventually. So what are the core ingredients? It's working in this community-based outreaching way. It's just open door, standing on a square, everyone is welcome, just for a chat. It shouldn't be about anything very specific. Just a chat is fine, and then perhaps the next time you can talk a bit more about health. So it also takes time to build that trust with the person living in socioeconomic vulnerable circumstances. So trust is, in a lot of senses, very important for this health kiosk. It's open to everyone, so everyone is welcome, and it is then actually a hub or a meeting place. So as already said, the person running the kiosk, she facilitates interaction by referring people to organizations, other organizations, but she also facilitates interaction between organizations within the community, something that we didn't expect at first. Then there is a provision of accessible health information using visual materials, also to overcome the language barrier. Patricia already said that is a challenge. We have worked with a local intern who spoke one of the languages that we don't speak, so that we could accommodate also people from Afghanistan, for instance. But it would be interesting to work with more interns to facilitate more interaction with different groups who don't speak Dutch, English, French. We also work with the community health workers, another passion of mine, and that is like people from a community who provides basic health services. And those people often also speak a wide variety of languages, and they also provide linkages then to care, which is their main task. So you see here that nice linkage between prevention and care that we try to build. Not only health information is provided, but we also try to support people to put this health information in action. As Patricia already showed, medical students come and take basic parameters about blood pressure, etc. They give some basic advice, and then people are referred to put this advice into practice, to going, for instance, to the free movement coach who is present at the kiosk. And then something very essential is also to work in a very flexible way, because we have to adapt along the way, learning by doing, making mistakes, for instance, organizing an information session where hardly anyone showed up, where we thought like, this is probably not the best way to convey our message. So it's really learning by doing. This requires flexibility from the team, but also requires flexibility from funders. And there you sometimes have the difficulty of funders wanting immediate results, which is quite a difficult thing for a project like this. And you see here a list of the people who are involved, but we already mentioned it, and I see that I'm short in time, so I'll skip this. ICC provides us also with inspiration for how we can make it even better, because the kiosk can definitely still improve. So co-creation with the members of the community would be something that we really want to focus on. Also including strategies to include people's life goals, and also a closer collaboration with primary healthcare providers. So quickly, some final thoughts. It's a grassroots innovation with a lot of space for experimentation, but we do have challenges of finding sustainable funding, which also makes it quite hard to keep on experimenting because there is still a lot of need for that, but we spend a lot of time searching for funds instead. It is a slow social process of building the trust, of building the community, but once you're working on that, you're able to really change people's lives within that small community. There is a flexibility required from all partners involved, but it also keeps it exciting. But there is definitely a need for further development. So we hope in the future we find further funding to keep on developing it and improving it. Thank you so much. If you have any further questions.
Thank you very much, Caroline and Patricia. And we're short on time. Unfortunately, we are not able to take any questions. But if you have any questions, you can certainly put those in the Q&A or speak to Caroline and Patricia at the end. So our final presentation for this session will be given by Dr. Melissa Northwood. And Melissa will be speaking on assessing the scalability of a community-based self-management intervention for older adults with diabetes and chronic conditions, the Aging Community and Health Research Unit Partnership Program. So welcome, Melissa.
Hello, everyone. Thanks for staying. I'm really pleased to be here, and I've just been enjoying the conference so much, so thank you all for welcoming us. And I'm pleased to present on behalf of our team, many of whom are in the audience today, so shout out to you all. Okay, so I thought I'd start by describing the program that I'll go on to explain how we determined whether it was ready to be implemented in the real world. So the components of this program were based on co-design with older adults with diabetes themselves, other healthcare providers, published research, and also older adults caregivers. So it's a 6-month program that's delivered by an interprofessional team in primary care that includes registered nurses, registered dietitians who are certified diabetes educators, and a community program coordinator from a community agency, so like a kinesiologist. And the core components that are included in this program are up to 3 home visits, although at the time of this study, it was during the pandemic, so they became virtual home visits that were done either by telephone or video conferencing by the registered nurse or the registered dietitian. There was up to 6 in-person or virtual wellness groups, and these groups included health education, physical activity, and an opportunity for older adults to provide some peer support and socialize with each other. There was also team-based care that was facilitated by monthly interprofessional team conferences, where they had an opportunity to review the client's care plan and goals and see how they were progressing, meeting their identified goals. And finally, there was tailored nurse-led care coordination to connect the older adults in the program to other community services they might need, and also keep their other primary care providers in the loop, and other specialists as well as required. And these are the intended outcomes of the program, was to improve mental and physical functioning, improve diabetes self-management, improve physical activity, reduce nutrition risk, reduce depressive symptoms, and also reduce anxiety, and reduce the cost and use of health and social care services. So here I'll situate what I'll be talking about today in the broader program of research. And on the left-hand side of the slide, you can see in the blue circles is how findings of previous research from the team built the evidence base for this research program and for the community partnership program. So the first study was to a population-based analysis of administrative data to understand the factors that are associated with high use of the emergency department in older adults that had diabetes and multiple chronic conditions. And this was to inform a recruitment of people with higher needs into the trial. Then the second study was a pragmatic randomized control trial that evaluated the implementation and effectiveness of this community partnership program in 3 provinces in Canada: Ontario, Quebec, and Prince Edward Island. Then at the top and the bottom of this image, you'll see some gray bars or boxes, and one is for patient and public engagement, and the other is for knowledge mobilization. And this government structure with patient and public engagement was one of the key places where we were able to start thinking about the scalability and ensure that what we were working on in the research program was going to work when it got out into practice. So the third study, and the one I'll talk to you about today, was focused on assessing the scalability of the community partnership program. And the research study was designed in thinking about how this program will fit into primary care practice and with our community partners. So scalability is defined as the ability of a health intervention that's been shown to work under a small scale or under controlled research conditions to be expanded to reach a greater population of eligible population while still remaining effective. So while the trial was run in 3 provinces, the pandemic halted the implementation in 1 province, so we were only able to assess the scalability in 2 of the provinces in Canada. So this was the process we went through to determine if the program was scalable. We formed provincial working groups, and these groups included members from the research program's governance structure, our public and patient partners, researchers, primary care providers, community organization members, as well as policy and decision makers. We conducted a document analysis and environmental scan to see where the program might fit. We also interviewed key informants with people in our health ministries and that were and senior leaders that would be involved in deciding whether this program would go on to live at the end of the research study. And our working group members kind of pointed us to who would be the best people to talk to there. We held virtual scalability assessment workshops where all of the participants rated the scalability of the program and identified the components of the intervention that would need to be strengthened and some barriers that would need to be addressed in order to move forward with implementation of the program in each of the provinces. And then finally, we shared the reports with everyone that was involved in the project of the findings of the scalability assessment. So this is the tool that we use, the Intervention Scalability Assessment Tool, to assess the scalability of the program. This tool supports a group working through a systematic assessment of a program to figure out if it's fit for use in your setting. And it consists of 2 main parts and 10 different domains. So the first section, we'd look at the problem itself, which would be older adults living with diabetes and other chronic conditions. The intervention, we looked at the political context, the evidence of effectiveness of the program from the trial, and the intervention costs and benefits. Then in the second part, we assess the fidelity and adaptation of the program, its reach and accessibility, where it would go, what delivery setting and workforce might be able to take it up, the implementation infrastructure, and the sustainability. So during those virtual workshops, we had each of the participants, there's readiness questions that are posed as part of this scalability tool, and we had them kind of reflect on them and then rate how ready was this program to go from 0 to 3. And then we, in real time, averaged the all of the raters' scores across each of the domains to show back to them for some discussion. And then we also organized our scalability report by these domains. So it was a really helpful tool to keep us organized. So here I'll show you a radar plot that was generated just in the one province in Ontario. But you'll see again here, each domain is rated from 0 to 3, with the higher scores indicating more readiness for scalability. And both of the provinces highly rated potential scalability across all the domains. So they were falling between 2 and 3. And in both provinces, they really felt that the managing and supporting older adults with diabetes and multiple chronic conditions was a significant problem that warranted the scale up of the program. So that was A1, that domain. In A2, they agreed that the key components of the intervention were reasonable and really would meet the needs of older adults. They did rate the evidence of effectiveness the lowest, so that's down at A4, as we had no statistically significant differences between the groups in the current trial. And that would be a whole 100-minute presentation probably, but we had consistent qualitative findings, positive results from older adults and the providers, and they acknowledged the impact of the pandemic on the trial. And they also thought, well, maybe we didn't measure the right outcomes, so they suggested some different outcome measurements for the program going forward. They Over in B2, in both provinces, they recommended refining the inclusion criteria to the program to try to target older adults that were more at risk. So we had included older adults over 65 living with diabetes and multiple chronic conditions. But in Ontario, they suggested targeting racialized older adults, as they felt the program would have a bigger bang with that group and could be tailored to their needs. And then in Prince Edward Island, they really wanted to focus on older adults who are high users of the healthcare system. And then in terms of B3, the delivery setting and workforce, I can imagine you can relate to this, that lots of challenges in figuring out where the program might be able to live given current health and human resources challenges coming out of the pandemic. But in Prince Edward Island, they said, yes, this is going to be a good fit in our primary care systems. But in Ontario, they were a bit worried that finding sustained funding in primary care might be a challenge. So to summarize, these are some of our key learnings, and I really feel like these are almost some of the key themes across the conference, that context really matters. And even though the design of the program was based on input from older adults and best practices and current evidence, you really need to look down at the provincial level and even further to the city and neighborhood level to see, is this program the right fit? Different perspectives are essential, which all the other presenters have been talking about, and particularly including the patient voice. And while we had a lot of consensus during the scalability workshop, the policymakers, health and community care leaders all brought very, very different ideas to the table that would really inform our next steps. And finally, when you are looking at taking your research out from a research into the practice setting, there's going to be tensions, and it's really important to consider all different types of evidence. So, for example, the participants had a lot of enthusiasm for the program, and they really wanted to focus on different groups of older adults who they thought would benefit. And as researchers, we were like, but we don't know who would benefit. We don't know where to start next. So that brings us to our next steps, which is really to work with our community partners to identify a priority population who would benefit the most, and then hopefully scale up the community partnership program, starting in neighborhoods, starting in communities, and seeing where we can go from there, and gathering more information as we roll along. So just to close, I'd like to acknowledge our very large team of researchers and patient partners and policymakers and knowledge users across the project in Canada, as well as, again, here are all the organizations that we partnered with that view with scale up in mind. If we worked with the right people at the start, it would help translate this research into practice. And finally, a big thank you to all of our funders. Thank you. Thank you, Maureen.
Thank you very much, Melissa. Do we have time for questions, Mandy? No. Okay. Okay, unfortunately, we don't have time for questions, but thank you very much for excellent presentation.
Thank you.
And thanks to all of our presenters for your excellent presentations, and to you, all of you for your attention. Thanks very much, and have a great afternoon.